Good afternoon, everybody. Once again, I'd just like to thank everyone for inviting me. It's been my great pleasure to be in Cairo for this meeting. So what I'm going to talk about is reproductive and endocrine issues in patients with thalassemia. And the aim is to cover these key things. One is, why do endocrine complications develop? And what are the typical endocrine complications we see in patients with thalassemia? And then I'm going to talk about management of some of those endocrine complications, particularly around diabetes management, and then go on to fertility management in pregnancy, fertility management and pregnancy management in thalassemia major patients. So why does endocrine complications develop? Well, it's mainly because of transfusional iron overload. We know that with each unit of blood, our thalassemia patients receive a lot of iron. It's about 200 milligrams per unit, and over the course of a year, the patients will accumulate anywhere between 4 to 10 grams of iron per year. Aside from using iron chelation therapy, there is no other mechanism for excreting that iron, and that iron will eventually be deposited in different tissues and different organs and result in damage to those organs. So we know that the liver is a primary site for iron storage, but if liver iron deposition is exceeded, then iron will get deposited in other tissues, and particularly the endocrine organs, pancreas for the diabetes, and then cardiac iron deposition resulting in cardiac failure in some patients. Now, the common sites for endocrine damage are the pituitary, and that usually develops very early on, and usually before the age of about 12, and the typical presentation is hypogonadotrophic hypogonadism. And essentially what it means is that the patient fails to go through puberty and requires puberty transition therapy to help them move into puberty with hormones. Hypothyroidism is very, very common in the thalassemia population. Hypoparathyroidism, again, common in the thalassemia population. And then diabetes, predominantly seen nowadays in older patients, but there is an ethnicity risk with diabetes, and that may explain why there are variable differences in diabetic populations in different areas and in different regions. There are, however, rarer endocrine damage sites, particularly the adrenals, and also growth hormone deficiency. And growth hormone deficiency, not in young thalassemics, but actually in older thalassemic patients. And we've got, at the Whittington Hospital, we've got a couple of patients who are growth hormone deficient with beta thalassemia major, and they're in their 40s and 50s. So there's been a lot of literature recently on endocrine complications in thalassemia major patients. And the Dubai group recently published, Behul et al., they published a paper very early this year on 382 patients with thalassemia. And it's a predominantly young population. The average age for their patients was about 15.4, and I think the oldest was around the mid-20s, so a very young population. And if you look at the complication rate, they've actually got a reasonable number, in fact, of patients who are diabetic, a large number of patients who are hypogonadal. And this is patients who have been given optimal therapy from a relatively early age. The other interesting observation that this publication had was that splenectomy status impacted on the endocrinopathy status. So people who had been splenectomized had a higher risk of endocrine complications. That's quite interesting because we know that the spleen is a site for macrophage iron storage, and it may be that once the spleen is removed, you develop iron-related complications in other tissues at an earlier age before you would ordinarily develop them. And Gambarini published a very long cohort of patients. It was almost 20 years worth of data, and they published in 2007 in 273 patients data on their endocrine risk. And what they did was they actually divided patients into 3 separate cohorts. Cohort 1 was the oldest population of patients. These were patients who were born from about 1955 to late 1960s, and these were patients who weren't collated at an early age. And what you can see is that the average endocrinopathy rate is actually quite high for all common endocrinopathies, but the incidence is much, much higher in patients who are older. And I think that will hold true for the majority of our patients as well. And of course, Bogner and Pignati's data in the 1,000 patients Italian study again showed that endocrinopathy was very common, particularly in the older cohort, but in the younger generation, these are patients born after 1980, the risk of endocrinopathy was much, much lower. And the recent publications on endocrinopathies from rare sites are Kinselli published in 2011 in 25 patients, a low IGF-1 beta, suggesting growth hormone deficiency in patients with thalassemia major. But when they gave the growth hormone suppression test, they found that only 8% of the patients actually had genuine growth hormone deficiency. And an interesting observation was that HCV infection was associated with a lower IGF-1 beta, and that is a very interesting observation in this population. Maybe, of course, for the quite profound fatigue that patients get, particularly as they're getting older. And then Saatchi in 2009 published in 124 adult patients a suboptimal cortisol response to patients following a cortisol stimulation test. And this is in patients who had normal 9 AM cortisol and normal urinary cortisol secretions. But when you actually gave them a suppression, a synaptolin test, they actually had an abnormal response, which was a suppressed response. This might partly account for why our patients don't seem to fight infection as well as the general population, and why infection is becoming a more frequent cause of death in patients with thalassemia. It may simply be that they're not able to mount a good enough adrenal response. So now on to the Whittington data. We've done quite extensive audit in our patient population over the last couple of years, looking at the endocrinopathy rates. And we have to remember that we look after one of the oldest population of thalassemics in the UK and possibly in Europe. So we had 94 patients who'd had all full tests done at the right times, including cardiac T2 star assessments. The median age of our patients was 37, but the age range was between 18 and 59. We purposely excluded the children because, in fact, we know that none of the children have got any of these. So we knew that the children were all completely clear. And interestingly, we found that 60% of patients had impaired glucose tolerance. Now, impaired glucose tolerance could be frank diabetes, it could be that the patient had an impaired fasting glucose, or it could mean that the glucose tolerance curve when the patient was given a glucose tolerance test was impaired as well. So about 60% of patients had impaired glucose tolerance. And if you think about the data I just showed you, that is much, much higher than the populations in the other 3 studies. Now that may partly be because around 50% of our population is of Asian origin. So that may be a reason that there's an ethnicity link associated with the impaired glucose tolerance, and maybe we're seeing or we're picking up early type 2 diabetes. But also the important thing is that the majority of our patients are actually older, and the average age of our patient is between 35 and 55. So it's a much older cohort of patients who are probably already prone to type 2 diabetes or insulin resistance. 64% of our patients had hypogonadism, and this is in the older population, and about 14% with hypothyroidism and 13% with hypoparathyroidism. Now, because we've been doing cardiac T2 star scan assessments since about 1999, we were able to look at the link between myocardial loading and the risk of developing endocrinopathy. And in fact, the risk of multiple endocrinopathies is definitely correlated with the presence of a low cardiac T2 star. And also, the risk of diabetes correlates very nicely with patients having a low cardiac T2 star. That's not unsurprising if you think about it logically, and that patients only develop iron in the heart when they've been very severely and heavily iron overloaded for a long period of time. And we know that cardiac iron is a late event, whereas endocrinopathy is an earlier event. And it may be that this is just a longitudinal natural progression of severe iron overload, which is why there's that correlation. We also had pancreatic signal intensity ratio results available from our patients, particularly the ones who were scanned in 1999 down to 2003. And interestingly, the pancreatic signal intensity ratio was low in all of the patients with a mean of 0.5. However, it wasn't actually associated with either a cross-sectional or a longitudinal risk of diabetes. But having pancreatic low SIR was associated with having a low cardiac T2 star. So that's just data from Whittington around the endocrinopathy issues within our population. And in fact, I think to be a good thalassemia doctor, you've got to be a pretty good endocrinologist, because you see an awful lot of endocrinology problems within the patient population. Now, the management of diabetes, for the last 5 years or so, we've been doing a combined multidisciplinary clinic with my diabetes colleagues, and we see the thalassemics who are diabetic in a joint clinic every 3 months. And the clinic, I think, has had a very significant impact on the overall diabetes management of our patients. So in a new diabetic patient, if they're severely iron overloaded and there's no family history of diabetes, then the first regime to initiate is insulin. And they're referred to the diabetes team, and they're referred to the dietitian for dietary advice. We also run a diabetes education program called the Windfall program, which actually teaches patients about management of insulin-dependent diabetes in a very, very focused way. We monitor our patients with monthly fructosamines, and the commonest insulin regime for our patient population is the basal bolus regime, which means a long-acting insulin at night and a diet-adjusted insulin doses during the day. So patients carbohydrate count, and then they'll give themselves the appropriate insulin dose using NovaRapid. If there is any evidence of insulin resistance at all, so if the diabetic patient is using very high doses of insulin, or there's a family history of diabetes, you can, and we do, very commonly put patients on metformin as an adjunct therapy. It's not as monotherapy, it's as adjunct therapy to the insulin regime. And in fact, this does improve glucose tolerance it does improve the diabetes control in these patients. In the older thalassemia major patients, and we've got quite a few of our older thalassemia patients have got very impaired glucose tolerance or have become diabetic, they do very well on oral regimes because the predominant cause for diabetes is actually a genetic or a natural tendency for them to develop type 2 diabetes. And they're being managed very nicely with metformin and oral hypoglycemic agents. What's really critical is that the management of diabetes in thalassemia patients has to be multidisciplinary with very active engagement with the endocrine team and also appropriate diabetic monitoring, which means annual eye tests, urine albumin tests and things like that to ensure that patients don't develop pathology related to the diabetes. What I can say is that virtually all of my diabetic patients say that the worst thing that has ever happened to them in their lives is the development of diabetes. The thalassemia fades into insignificance in comparison to doing insulin 4 times a day and blood sugar testing 5 to 6 times a day. So the issue is try and avoid it if you can. Now, fructosamine monitoring is really important, and I just want to remind everybody that HbA1c, pre and post transfusion, is affected by dilution, and it will therefore give you a very inaccurate result. This patient's HbA1c was 14 pre-transfusion. Immediately after transfusion, it had gone down to about 9. So it will give you a very inaccurate result, and HbA1c should be, if you are going to do it and you don't have any choice, then you should do it pre-transfusion. That will give you a better idea of what the diabetic control is. Otherwise, choose to do fructosamines. Fructosamines are not affected by the transfusion at all. Now, one of the things that we do know in our patients is that compliance is affected by a variable number of factors. But if your compliance with your iron chylation is bad, your compliance with your diabetes is bad. So this patient's average fructosamine was 350, their ferritin went up and their diabetic control got worse very significantly. So you can often pick up, because we monitor the fructosamines much more frequently, you can actually pick up falling compliance very early on in these patients. And again, the patient intensified their iron chelation and they got more focused with their diabetes management. So how do we monitor for growth in our patients? Well, the prepubertal growth problems are mainly due to insufficient blood or too much iron. Sometimes it's due to overpopulation, but we do our very best to avoid that. And growth hormone deficiency in its own right is extremely rare in the general thalassemia population, but in particular in young patients with thalassemia. Routine tests are ones that everyone's familiar with: the ferritin, the bone access, thyroid. Sitting and standing heights are very common and should be done, and X-ray of the spine along with the growth hormone stimulation tests are also very important in monitoring for prepubertal growth failure. Now, the commonest reasons for pubertal growth failure is actually hypogonadotrophic hypogonadism, and as I said, it tends to develop by the age of 12, and it's nearly always related to bad inoculation over a period of time during childhood. Growth hormone deficiency can occur, but again, as I said, it's relatively rare. And again, to identify that, sitting and standing heights, monitoring of the endocrine profile in children who should be going through puberty and who are not, you will see that the testosterone fails to rise and there's no movement with regards to the FSH or LH families. And then X-rays of the left wrist for bone age will identify if there is a delay within that. And again, the IGF-1 beta. So in the UK, all patients should have estradiol, testosterone, FSH, LH monitoring 3 monthly. Glucose tolerance, we generally start by the age of 10 to 15 years of age. But if there's a family history of diabetes, we will often start that earlier. So 10 years of age in diabetic family history, and about 15 in people without. Fructosamines in diabetic patients, vitamin D and parathyroid access, and we only start to do bone density scan in patients once they've gone through puberty. Now, vitamin D is incredibly topical at the moment in the UK. There are white patients who've got rickets and white adult patients who've got osteomalacia. And it's been a bit of an unexpected finding, but what we do know is that in the thalassemia population in the UK, over 80% of them are severely vitamin D deficient, and that is predominantly because A, they're an ethnic minority, and B, vitamin D deficiency is prevalent anyway within thalassemia itself. So what we do is we assess the parathyroid hormone, vitamin D, calcium and phosphate, and if the vitamin D is low, it's very important to correct it with appropriate doses. For many years, we have been using insufficient doses of vitamin D to correct vitamin D deficiency, and in fact the doses that should be used are doses of around 20,000 international units on a weekly basis. And in fact, the average dose has been about 400 international units on a daily basis, which is not very good at all. If the parathyroid hormone is low, and that means parathyroid hormone deficiency, then you should correct vitamin D, of course, but you will also need calcitriol to support the next step in the pathway. And patients need long-term correction. There's no point correcting vitamin D and then stopping it, because they will become deficient again fairly quickly. So I'm now going to talk about fertility, because there's been lots of advances in fertility management. At the moment, in my hospital, we've got 3 thalassemic major girls who are pregnant, another 3 who are going through ovulation induction. This is going to be a very big year for our centre, because we have lots of babies coming. But we have actually had a very good result with all of our pregnancies over the last 20 years or so. Ariga published in 2010 data from 4 Italian centres, and they had 46 female major patients who had 58 pregnancies. Ovulation induction was the main reason for the pregnancy, 33 patients, and 45 singleton, 5 twin and 1 triplet pregnancy were the outcomes in those patients. In the singleton pregnancies, IUGR rates were completely the same as the normal Italian population, but they had a high risk of preterm delivery in about 32% of patients, and those preterm deliveries were mainly in the multiple pregnancies. And in the Italian cohort, they had quite a large, out of the 58 pregnancies, 52 were caesarean section delivery. 25, that's over half of them, were done as a caution, so just because people were a bit nervous. And in the others, the reasons were fetal pelvic disproportion, twin pregnancy, preeclampsia, and reasons that were mainly obstetric. Other publications, Bedouri et al. Published the UCLH data, which is the other half of the red cell disorders unit, and their data showed 36 females and 28 successful pregnancies. The average age was between 20 and 39, and 35% were above the age of 35. And interestingly, they had a higher incidence of intrauterine growth retardation than the general population. And Ansari published data from Iran, mainly in thal intermedia. There were 6 thal majors, and interestingly, all their pregnancies were spontaneous conceptions. So, in our centre, we've had 26 female thal major patients who've had 37 pregnancies. The age of first gestation ranges from 24 to 42, and in fact, we've got quite a few older thalassemic females who are pregnant, who are over the age of 38. Mean age of our patients was 32. 3 of those patients were diabetic. We've currently got 2 diabetic thal majors who are pregnant, and they do require very careful monitoring. 19 pregnancies were spontaneous conceptions, 4 were egg donations, 2 of those resulted in twin deliveries, and 13 were ovulation induction with 5 twin pregnancies. We allow up to 2 ovulations per ovulation induction cycle. If it goes above 2, then we halt the cycle and don't allow conception to happen. And 1 pregnancy is due to IVF. In our patients, only 16 deliveries were by caesarean, and virtually all the twin, apart from one of our patients delivered a twin pregnancy completely normally, and the rest of the deliveries were actually normal vaginal deliveries or assisted with forceps. Mean age at gestation was 37 weeks, so very few premature deliveries. Virtually every girl went to delivery on time. We have not found any evidence of IUGR in our population. The average birth weight of our population, including the multiple pregnancies, is about 2.3 kilos. Only 2 IUGR prem deliveries, and these were in older thalassemia major patients, and the deliveries were actually done at about 24 weeks gestation. So those babies, although they are completely healthy, completely well, they were delivered extremely prematurely. The mean cardiac T2 star pre-delivery was above 20, and post-delivery was also above 20, but you can see that we've done successful pregnancies in people with quite significant myocardial loading. Only 2 patients actually received Desfram during the pregnancy in our centre, and that was at about 25 weeks of gestation, and the doses were between 1 to 2 grams on 5 days a week. One of those patients was very heavily myocardially loaded, and the other patient had a Ferri-scan liver iron of above 43, which was extremely high. Now, in our male patients, because male fertility outcomes are not as good as female fertility outcomes, we've had 17 patients with 28 successful partner conceptions, 20 were spontaneous conceptions, 5 were IVF exceed, and 3 were spermatogenesis induction. And I think what's very interesting is that the spermatogenesis induction patients, the sperm production doesn't actually switch off immediately, and these patients can often have low-level sperm production even a couple of years afterwards, because after our spermatogenesis induction cycles, a couple of our patients have actually had spontaneous pregnancies with their wives without too much trouble. Diabetic patients who are going through spermatogenesis induction are extremely difficult to manage. It's very, very important to remember that really optimal diabetic control is critical. Sperm do not grow in sugar syrup environments, and they really do need as tight diabetic control as we do with the girls during pregnancy, and that means a fructosamine of between 300 and 330 for the majority of the time, and at least for the 3 months preceding the sperm banking or the attempted conception. It can take 18 to 24 months worth of hormone therapy to actually get sperm induction. My general experience is that for clinicians who are not experienced in this, they tend to stop at the end of 12 months, and that's actually not long enough for these patients. And it's very important to not be negative and to move on to testicular biopsy and ICSI if needed, because some of these patients may actually have sperm within the testes, which are harvestable and used for ICSI. And optimal iron diabetic control, again, is really critical in the male patients. So what do we do with our thalassemic pregnant girls? Well, pre-pregnancy planning is really important. They get a T2 star and periscan liver iron assessment. All girls get glucose tolerance testing, partner screening and counselling. And we work very hard for about a year to optimise their iron levels, which means that their target T2 star should be above 20 milliseconds. We do let them have pregnancies below 20 milliseconds, but it's only if they agree to chelate during pregnancy, their ejection fraction is stable, and their liver iron is less than 5. So it is dependent on them hitting all of those targets, or as many of them as they can. We stop all oral chelators 3 months prior to conception and convert all of them onto Desperal. All bisphosphonates are stopped 3 months prior as well. And all women with Thalassemia are started off on folic acid 5 milligrams daily at 3 months pre-conception. And if their vitamin D is not optimal, then we optimise. The majority of our pregnancies actually happen within the second or the third ovulation induction cycle. It's unusual for our girls to go to cycle number 5 or 6. And when they're pregnant, the aim is to keep the hemoglobin above 10. They're reviewed every month, both by obstetricians and haematologists. And they have a cardiac review at 28 weeks for delivery planning and a decision about is their heart going to be able to cope with a normal delivery. And if the cardiology team give the go-ahead, then the aim is to go for normal vaginal delivery unless there are obstetric reasons for not. Everyone is managed by a high-risk pregnancy team, and there are very active nurses supporting the diabetic patients through their pregnancy with very good diabetic control, and regular monthly monitoring via ultrasound for intrauterine growth retardation. Cardiac iron-loaded patients must start on subcut Desperal at about 25 weeks, and usually it's a low dose, so certainly a dose of below 30 milligrams per kilogram per day. Intrapartum care is the same for all women, apart from the fact that we put patients on Desperal at the time they arrive in labour, and the Desperal 2 grams 24 hours is kept on for the entire duration of their labour. It's very important to recognise the fact that venous thromboembolism is a common concern in patients with thalassemia, especially people who've been splenectomised and or who've had chronic undertransfusion and splenectomy. And so all patients are given VTE from prophylaxis, and patients with a history of VTE, post-splenectomy or transfused TIs are considered for extended prophylaxis for 6 weeks postpartum. Again, the primary concern is to reduce the risk of pulmonary emboli or deep vein thrombosis. This is my favourite slide. This is our recent pregnancies. Egg donation, normal, all of them are normal deliveries apart from the twins. And this is an IVF pregnancy. This girl had a cesarean because she's got very severe pelvic disproportion, and she's currently pregnant again. These are some of our older pregnancies and outcomes with patients, and these are pictures on the thalassemia unit. So you can see that there are lots and lots of baby pictures on the unit to encourage the patients to have babies. And I just want to say thank you all for inviting me again, and to my colleagues, without whom I wouldn't be able to do the work that I do. The key person here is, of course, my nurse, Emma, and Prof Porter. And thank you all very much.
Thank you very much, Professor Farrukh. I would like, if anyone has questions for Dr. Farrukh, because she has to leave. So if there is a few questions for her. أسئلة؟ أي حد عايز أسئلة؟ تفضل تفضل.
Levels at about 10 during pregnancy.
Yes.
Pre-transfusion time?
Pre-transfusion.
Wouldn't this be a bit too aggressive to transfuse them like that?
No. For the Thalassemia.
I'm an obstetrician, so
Right,
I'm not
okay.
from your side, so that's why it might seem.
For the thalassemia major patients, the average pre-transfusion hemoglobin prior to pregnancy is supposed to be about 9.5 grams per deciliter. If we let them go below 10, A, you put their heart under stress because the cardiac output's gone up by 30%, and B, you're risking IUGR. And I'd be very interested to look at the ECH data to see whether the IUGR rates were actually related to more significant anemia, because we're slightly more generous with our hemoglobin targets for our pregnant girls. The aim is to keep them completely functionally as good as they can be, and we don't normally have any problems with them developing fluid overload or anything like that. They're very used to running an average hemoglobin of between 9.5 and 10.
I mean, the main reason why I'm asking you that is that we have quite a bit of experience with thalassemia minor, for instance, and when we're following them up, we're not really very much concerned about the hemoglobin floating around the 10 because we know that they're very tolerant to that.
Yeah, no, thal minor is a very different disease, and one of our big concerns is obviously the development of extramedullary hemophysis and bone marrow expansion in thalassemic major patients, particularly if they're under-transfused. So we do keep the hemoglobin at 10 or higher.
But I want to ask the level of fertility, about the level of serum ferritin during pregnancy.
During pregnancy, very important question. It does go up, there is no question, but it doesn't go up as much as you would expect. And one of the reasons why it doesn't go up as much as you would expect is because the baby's using some of the iron from the blood transfusion. And in general, we see about a 500 microgram increase in the serum ferritin on average over the course of a pregnancy. Clearly, the more severely iron overloaded the patient, the higher the increase you're likely to see. So you may see 1,000 to 2,000 increase, but the majority of patients with ferritins of below, our target ferritin is around about 1,000 to 1,500. The majority of the girls go up to about 2,000.
Above 1,500 you start chelation?
No, we don't start chelation unless there is presence of iron in the heart, or unless on an MRI scan the liver iron is very high. Now, if you remember what I said, we do liver iron assessments pre-pregnancy, and the target liver iron is 5, which is lower than the international standards, which are less than 7. So we do get them down very low, and we therefore don't generally worry about chelation during pregnancy. It's only if they've got iron in the heart that we worry.
But if you want to start during the second trimester.
It's basically around 25 weeks,
Yes,
so it's mid-second trimester.
Okay.
Yeah.
Thank you.
And Desra's safe at that time.
Thank you, Dr. Farrukh, for that very interesting and important presentation, actually. For chelation therapy during pregnancy again, you start chelation therapy again at 26 weeks gestation, right? You don't start at the beginning of your pregnancy.
No, we don't. The main reason is that there is concern about toxicity with Desra in the first trimester, and that's the main reason we avoid it in the first trimester. But you can start chelation as early as 20 weeks. And we had a patient down at ECH whose T2 star was 7 milliseconds in the heart, which was not very good. And she started chelation at 20 weeks, and the baby's outcome was very good.
As regards the hemoglobin level, you're saying that hemoglobin level should be pre-transfusion more than 10 grams. But in pregnancy there is hemodilution, which meaning that the hemoglobin may be higher, but the hemodilution gives you a false impression of the level of hemoglobin. So why you should maintain it above 10 grams?
The main reason we keep it above 10 is purely because patients get very symptomatic with pregnancy, with fatigue and all of those things. And we all know that with thalassemia there's a huge psychological link between the hemoglobin value and their symptoms, particularly their back pain and other symptoms. So it's not a big difference between the hemoglobins of 9.5 and 10, and we tend to try and keep them around 10 just so that the patient themselves feels better. We haven't noticed any problems at all with either fluid retention or any kind of clinical outcome that would suggest that there was fluid overload in the patients. And in fact, our IUGR rates are actually very low. It may be that the transfusion intensity is playing a role in that, and that people in maternal anemia is less impacting on the growth of the baby.
What about the spleen with pregnancy?
Again,
The spleen with pregnancy.
a big proportion of our patients are post-splenectomized. If you see that the majority of our patients are older anyway, quite a few of them have been splenectomized, and there hasn't been any issues in the splenectomized versus the non-splenectomized patients.
Thank you very much. Thank you very much.